Hi, everyone. My name is Neda Shamie, and I'm delighted to be here with you tonight. Over the next hour or so, we are going to be talking about insider perspectives about the Vivity and PanOptix. I'm a cornea, cataract, and refractive surgeon at the Maloney Shamie Hura Vision Institute in Los Angeles, and I'm delighted to be here among my dear friends who are my expert panels. These are friends I have, our practices have evolved together. We have learned a lot from each other, and I'm really happy to be here with you to talk about PanOptix and Vivity. Actually, PanOptix with but you can probably comment a little bit about Vivity if that topic comes up. But later on, we'll be talking more about Vivity.
Yeah.
Nice to have you here.
Thank you, Neda. Great to be here. I'm super excited to be with this great panel. My name is Rob Weinstock. I am from Tampa Bay, Florida at the Eye Institute of West Florida. I'm a cataract and refractive surgeon.
Fabulous.
Hi, I'm Dagny Zhu. Super honored to be here. I'm a cornea cataract refractive surgeon practicing private practice Los Angeles, kind of down the street from you, further on the other side in California.
Although down the street in LA is like 5 hours.
Exactly. Give or take on traffic conditions.
And I'm Dr. Mark Lobanoff. I practice up in Minneapolis, Minnesota at Ovo LASIK and Lens. I'm a cataract and refractive surgeon. Very excited to be here talking about this topic.
I'm so happy that you're here. So let's dive right in. We're focusing on presbyopia, correcting lenses, and really the market has been speaking for itself in many ways. I mean, this has been definitely a topic near and dear to our hearts. I know for the last 10 years plus, we've been talking about this at panels here and there, but the climate has changed, and it's changed in the most positive way. I know that the penetration of advanced technology lenses, as we all know, had been pretty steady and flat for a long time. And it was kind of right around 14% for many, many years. It actually started at 7% when I first started using presbyopia lenses and toric lenses and such. But it laid flat at about 14 up until about 2019. And I think we can all probably remember when PanOptix became available to us. How long were we waiting for the first trifocal to hit the market in the US? And it was one of those things, we all know where we were when that announcement was made, right?
For sure.
And it really changed our approach to patient care. I think as refractive cataract surgeons, there was absolute need for a trifocal. And then what we saw was what was really impressive and unprecedented. And that is when a new lens had come into our hands prior to PanOptix, we would always see a blip in the penetration and then a steep dive because what was promised was not always what was delivered. And yet what we see from this graph is that there was a steady rise in the penetration into the market, which speaks for how wonderful PanOptix was in our hands and how it delivered on the promise.
And really, this tells us that the market was telling us we need a trifocal. The question was, could we actually build a trifocal that worked? And Alcon was the first ones that showed us it can be done.
Yeah, absolutely. And then Vivity launch also was a really wonderful addition to the advanced technology lens option. And, at the later session, we're going to talk about how that fits in our practices. And so we saw a 6% increase in market penetration of advanced technology lenses with the advent of PanOptix and Vivity. And then it's kind of stayed steady. But 1 out of every 5 patients is now receiving an advanced technology lens around the country in the US. Now, my practice is a much bigger penetration. We have close to about 60% penetration in our practice. We're in West Los Angeles, different demographics of patients, and also our practice is positioned that way. And I know your practices also have a higher penetration. What we do know is that more than 40% of patients want to have the option of advanced technology lenses. If they're offered the option, likely they will want to choose that option. And what is your thought about 1 in 5 is great. It is better than it was 14% for many, many years. But do you think we can do better than this?
I think every demographic and practice is different. Every surgeon's different. Their comfort level with these technologies. Many of us had a history of working with technologies that had challenges. Profiles where the patients would complain of dysphotopsias or other quality of vision issues. So a lot of surgeons get burned and they move away from a lens. But like you were saying, the fact that this penetration has continued to rise or at least stay steady shows that long-term the patients are happy, and we're seeing less patients who have complaints. And overall satisfaction with the technology. And with the PanOptix Pro, it's even levels the game up some.
Yeah.
So I think that coupled with social media and patients' education in this era of patients wanting to free themselves up from glasses and take advantage of technology at the time of cataract surgery, I think we're going to continue to see this continue to take off and blossom in all our patients.
I think in my practice with the advent of PanOptix Pro and the benefits we'll talk about in the next few minutes, most definitely I have greater confidence even recommending a trifocal to my patients.
Yeah, I think it's sort of changed the way that we as surgeons present options to our patients. With the innovations now that we have with PanOptix Pro, the technology has gotten so good that I feel comfortable offering a full range vision lens or trifocal as the default choice to that patient walking through my door. And then we'll go through the checklist, maybe exclude those who may not qualify. But I think really resetting a full range vision lens as a default rather than a monofocal is the way more and more of us cataract surgeons are thinking.
Yeah, most definitely.
I think not only can we do better, but we should do better. Because I really feel in my practice with my patients, when a patient is doing well with the PanOptix Pro, they're happier than any other patient I've seen because they have a full range of vision that is clear, good contrast. And so the fact is, in the past, the technology was limiting our market share. Older designs didn't have the focal point at the right place, had too many issues with glare and halo. And those issues limited it to a very specific set of patients who might tolerate those things. As the technology's gotten better, we should see a broader market accept this lens and do well with this lens.
Dagny touched on this. Before, with the older technology, I used to personally wait until the patient asked for spectacle independence.
Yes.
So my first inclination was not necessarily to recommend or really be motivated about that option. It wasn't until the patient was highly motivated. Now the technology is surpassing our expectations such that a patient could not even be asking for that. But I feel the onus is on me as a surgeon to really offer them the best option. And I set aside the cost, and the patient's necessarily, incoming expectations, set aside that and really think about that patient as though these are my own family members. And I think to myself, what would I want my mom, my aunt to have? And with that mindset, I look at the whole of the patient's eye and their expectations, their baseline health, and I say, I think this is the best option for you. And the trust in the technology that we'll talk about is really given me that confidence to be able to move forward with that attitude rather than wait until the patient asks. So this shows us what the 20%, what does that entail? And it really is torics and presbyopia correcting lenses are matched, and then the adjustable lenses are taking up about 2% of the market. So, again, I think there's real opportunity for growth, most definitely in toric and presbyopia correcting lenses. And we're hopeful that after today's discussion, that more among our audience will consider adding these options to their patients' profile and options. All right. So as far as Alcon, here we are. We talked about how Alcon was the leader with the first trifocal that was gifted to us in 2019 by Alcon, and then they again Vivity with the first non-diffractive extended depth of focus lens. And now with PanOptix Pro, they have remained a leader in the field, and I think it really speaks to their commitment to optimizing the outcomes for our patients as well as for us, because, of course, our happy patients leads to better practices for us. What are your thoughts on this?
Well, it's wonderful that we have companies like Alcon that are dedicated to providing us with tools and technologies to help our patients. And to have a whole platform of different lenses, whether it's a monofocal or a toric or an extended depth of field lens or a trifocal, it allows us to choose what the best technology is that we recommend for our patient, give that patient the best chance of success. And the fact that they've shown continued innovation, we know there's going to be continued improvements. I think it's reassuring to all surgeons to know that there's someone on our side that's going to help us, do what we do best.
Yeah, I think Alcon continues to be a leader because they're always thinking about what's next. How can we take this great product and make it even better? I think a lot of us thought it was kind of crazy that they wanted to improve upon the PanOptix when they had already established dominance in the trifocal field. It was already giving great, reliable outcomes. And a lot of us had, I think, the opportunity to talk with some of their R&D people. They want to hear from us as surgeons, how can we take this already great lens and make it even better? And, a lot of us said, whatever you do, don't take away any of the things we already love. Don't compromise anything to make it better. And honestly, Alcon has delivered, and that's why they continue to be a leader in this field.
And I think that was our fears. We loved the PanOptix so much. We were so impressed with it that when they said, we're going to tinker with this, I was a little bit nervous.
Right.
Like, I don't want you tinkering with this. My patients are pretty happy. But it's been an improvement. They did a great job. They didn't stand on their laurels. They didn't stand on the fact that they had the majority of the market share. They said, we want to make this better. How do we do it? And they went and they made it happen.
Well, let's first talk about the PanOptix. We all have had patients who come in, and again, we know that this is a great lens for that patient. They have healthy eyes. They want, and they are motivated to have spectacle independence, but they're weary, right? Because their neighbor had another trifocal or multifocal or bifocal previous generations, and they're not happy with the results. And so I think it's really important when we talk to our patients to highlight that your mom's, lens is not the lens that I'm offering, your neighbor's lens is not the lens I'm offering here, and that there's generational improvement. And PanOptix is not a traditional trifocal. And we all know this, right? With the PanOptix, it's non-apodized. And it also, one of the greatest benefits it offers compared to other trifocals is that it has moved the mid-range to a more acceptable, much more functional level, or distance rather. The other trifocals, mid-range is about 32 inches. And for us mortals who don't have really long arms, Rob, how long is your arm? Not that long. Although you do a lot of selfies, so I don't know. No, so anyhow, so 32 inches is other trifocal. It's too far for mid-range, but with the PanOptix is brought to a much more acceptable 24 inches. Yeah. And the non-apodized also really differentiates it from other traditional trifocals. How about going from PanOptix to PanOptix Pro? As you said, Dagny, Alcon wasn't just sitting on their, hands, and they said, let's continue to improve this, right? And the way they've improved it is they've lessened by just very precise changes, they've lessened the light scatter by 50%.
Right.
Now, how does that translate into what you see in your patients? 50% less light scatter means what in your patient's experience?
Right. So it was already good when they were using 88% of light. Now it's 94%. And it's a 6% jump, but you're right, that translates into 50% less light scatter loss. So that's huge. And for me, I think that just means the lens is utilizing the energy more efficiently and effectively. But we're also losing light scatter. So in my patients, some of the early ones that I talked with to really differentiate, what have you noticed with this lens? A big one is a lot of them told me that, the quality is excellent, and the nighttime driving that you warned me about with the halos and glare, I haven't really noticed it too much. And I do feel like, in my experience, that's an improvement upon the old PanOptix. I'm not going to say that's going to be the truth with every case, or you're going to have that with every patient. And I think until we do large clinical trials to kind of differentiate some of these nuances, it's going to be hard to say. But at least in my perspective or my experience, certainly no worse than the original PanOptix, which is what I really wanted, not to compromise anything. But I do think there are small improvements that I've noticed and heard from my patients as well because of this increase in light utilization.
Yeah.
I learned the most about a lens's performance in my practice from my workup techs and the optometrists I work with, because they're the ones, when there's a problem with a patient, that come to me or they tell me that I should, change what I'm doing. And what I really noticed with the introduction of the PanOptix Pro is that we were already having very, very few patients that were unhappy or had significant complaints. But it just went down a notch to where it's all, as long as the patient has a healthy eye and is a good candidate and their expectations are set, it's extremely rare to see a patient in our practice who's dissatisfied or even complaining of anything mild with this lens, to where we've just become more and more comfortable, like you said, offering it to people, recommending it to people, and giving them that opportunity to get a great technology in their eye.
And I just want to dovetail on what Dagny said. We've put in about 400 PanOptix Pros so far. We have not had a single patient want it removed because of nighttime issues. Okay. It's a really good record.
Yeah.
And I think it speaks to the 50% less light scatter And that light is not only being not just scattered, it's being focused into a usable portion of the visual field.
Mm-hmm. The other thing that I've noticed, because they're utilizing the energy more efficiently, they have great bench data showing that there's actually increased contrast sensitivity now.
Yeah.
When you've been putting your patients into the PanOptix Pro, they've been discussing clear, crisp vision, which speaks to that contrast sensitivity.
Yeah, it makes us more comfortable offering it to people that maybe in the past we were worried, like we always used to red flag, like say engineers or people that did a lot of night driving.
Yes.
Or people that did like low myopes that read with their glasses off a lot. We're worried about their reading vision might not be as good as what they were used to. I think it's broadened our ability to use the technology because the patients are so happy and they're not having many issues.
Yes.
I do want to emphasize, though, that still doesn't mean the word forgiving. It doesn't mean that you can implant it if you think there's other comorbidities or other issues. The eyes need to still be healthy. The ocular surface needs to still be healthy. But yes, most definitely it's given me more confidence. And I agree with you. I operate on the two eyes about a week apart. And I would ask at the bedside, how is your first eye doing? And with the PanOptix, patients were very, very happy. But they did comment maybe a little bit more about the nighttime visual aberrations due to the light scatter and such. And the complaints from my patients has been minimized to a point where it's less of a concern. I still state it. I still tell patients when I'm counseling them on this lens that yes, it utilizes more light than other lenses and definitely than the previous generation, and that it's going to give you great range of vision. You may still have nighttime visual aberrations as it's inherent to diffractive lenses, but it has been minimized to the point where if a patient's hesitant, but they're highly motivated for spectacle independence, but hesitant for diffractive, I'm much more confident to encourage them to pursue this option than I was with previous generations.
I think that's the biggest change is how the surgeon feels about, introducing this lens and the confidence that we now have. I have a few patients, actually two, who do have the old PanOptix in one eye and the new PanOptix Pro in the other eye. And the only reason they wanted, obviously, the PanOptix in the second eye was because they were already so happy with the PanOptix in the first eye, right? But given that we have this new generation lens, of course, I was very comfortable putting the Pro in their second eye. And I think any surgeons out there, if you have similar situations, it's perfectly fine to mix and match an old PanOptix and a new PanOptix Pro. These patients do really well. And both of these patients, again, still very, very happy. About 20/20 J1, J1 Plus in each eye. Really no noticeable differences that they could discern to me, which just highlights again that both IOLs are so good.
Yes.
And I think we're just building upon it. And I think it's those outliers that you might have. You may have fewer of those complaints. We might see that with larger clinical trials.
What I feel like I'm seeing anecdotally in my patients is a little faster neuroadaptation to that nighttime issue.
Interesting.
They all adapt to this. And when I did PanOptix, I would caution patients, say, look, the first month, you're going to see some rings. Month 2, there'll be less. Month 3, less. And that neuroadaptation, that process, I think, feels like it's happening faster.
Yeah. And that's a really important point in counseling patients for any presbyopia correcting lens is the neuroadaptation.
Yes.
And I spend actually quite a lot of time describing that to them. And I explain it's like, you get a pair of new pair of glasses and you'll notice the frame right when you get it and it takes time for you to get used to it. Or I point out especially if they have a big nose, I point out, now that I'm talking about it, you see your nose, but you won't if you're not paying attention to it because you've neuroadapted to the presence of that big nose.
Great example.
I have a lot of Persian patients with big noses. I'm Persian myself. So I think it's important for them to understand that it takes time to get adjusted to it. And I think knowing that ahead of time will give them greater confidence to really reap the benefits of this lens. Let's talk about the other big benefit that I alluded to earlier, but I'd love to hear, Mark, your experience with this because you have a very personal experience with the fact that this lens, the PanOptix Pro, gives you a really nice full range of vision and covers that mid-range very nicely.
I love this slide. So as we look at this slide, what we're looking at is the distribution of light for a variety of different lenses. And we can really see how the PanOptix Pro is different from everything else. Notice that top line, that yellow is continuous across the whole line. There aren't gaps in it. Now, I love the PanOptix. I put the PanOptix in my wife. And since it was my wife, I heard every day.
And you like your wife?
I do love my wife.
Okay.
Every day I'd hear how she's doing, the good and the bad, and mostly good. One thing that she noticed, though, is she could read really well. She could see her computer really well with the PanOptix, but there was a zone of about 2 to 3 inches beyond the computer that was just a little bit out of focus before the distance picked back up. Really didn't bother at all. Notice on the line, on the PanOptix line, there's that little spot where it goes black in the middle. That's where she was noticing that. Look above at the PanOptix Pro line. Notice that black area has been filled in. That mid-range, that 2 to 3 inch beyond your computer screen has now been filled in. They took the scattered light and they refocused it and made it useful. And I just love that about the optical physics of the design of this lens.
That's so important because we do have those patients who notice those gaps in your vision.
Yes.
Sometimes you think, no one's going to really value that range between intermediate and distance. Like, we don't really use that range, but you'll be surprised at how many patients come back to you and say, when a person stands right, or when a person stands right here, I can't quite make out their face as well.
Yes, absolutely. And it's that distance where let's say you're helping someone on their computer. You're a teacher, you're standing behind them, you're looking over their shoulder at the computer. That's the distance.
Right.
And now that's been filled in.
I think this is where the trifocal really was huge value, because before our PanOptix becoming available to us, we used to do a lot of mix and matching and trying to decide which eye should we do, the bifocal that gives you a stronger near and such. I think with the trifocal, it's become a lot easier to have those conversations and not have to worry about, in a cataract patient, which is dominant, which is not, and really truly give the patient as much freedom from spectacles as possible.
I think the PanOptix Pro, it almost bridges from the trifocal era where we were kind of like 3 separate zones and patients might need to find the sweet spot and you'd have to help them in the exam room, hold it in the right spot, you know?
Yes.
And some people are more patient than others and they do it. Others, they can't find that sweet spot and it takes them longer to neuroadapt or whatever you call it. What we're talking about here with the light, that utilization and what you described in your wife, we are seeing more of, like, even though it's a trifocal, it's functioning like a full range of vision.
Yes, Rob, I was going to say exactly what you said. I think the Pro takes the PanOptix from just a trifocal where you have 3 distinct points to a full more natural range of vision.
Yeah, it's very functional for patients. So you don't have to describe it so much anymore. You just say, this is going to be your most freedom from glasses. This allows you to focus at multiple different ranges so you can get the most natural vision
possible. And if you'll notice, it's not like they took the energy from one focal point and added it to that gap.
Right.
They're adding more overall light utilization, 6% more throughout the whole range of vision, so that you're adding to every focal point. Again, they're not compromising at any other distance, which sometimes you get with other lenses. Maybe the distance is a little better, but you lose a little near. Here, we're maintaining that. And speaking of neuroadaptation, my in-house optometrists, they're the ones who usually notice the biggest differences, and they tell me when we're using a new lens what they see. And one of them actually noticed, hey, I feel like patients are getting their near even a little faster than before, like their J1 Plus is kicking in sooner. So that actually reassured me, because I always feared that they were, compromising maybe on the near to deliver better, bridging, but that's absolutely not the case. And it's still...
I'm getting less calls the day after when the pupil's still partially dilated. Doc, are you sure you put the, trifocal in me? Because I used to get that call where I can't read. Oh my gosh.
Because it took some time.
It took some time. But now I think with the PanOptix Pro, definitely in my experience, as it has been for you, the patients are seeing close up faster and sooner. But again, this is all our personal experience, which is obviously, I think, great value to our viewers. But the product performance, we'll have to do a lot of studies to really truly differentiate. But I think it's really been wonderful kind of evolution of how we as refractive cataract surgeons have experienced this lens and have been able to implement it in our practices.
I don't know about you, but in the past, if I put a lens in and the patient came back and they're unhappy, I took it personally. It feels like I'm hurting myself when they come back and they say, we chose this lens and it's not working the way I want it to.
Absolutely. I think it's been a wonderful, wonderful, simplified the discussion a lot more. And then the postoperative management of patients, most definitely. So I think, again, I know we've talked about this a lot, but this is probably the most exciting modification of this lens, the PanOptix Pro, the value added to, as compared to the PanOptix, is the half the light scatter. And as was mentioned here, that translates into patients feeling like their vision is better quality than what we had laid out for them in our consultation because, of course, a diffractive lens, the onus is on us to make sure that we educate them about what to expect. But that discussion, for me, the chair time has shrunk because, again, I was really under-promising and really super over-delivering. And now it's gotten a lot easier for me to say, yes, I need to tell you this, but my experience with my patients has been that less and less patients are describing nighttime aberrations or visual aberrations due to the fact that this lens has a much better light scatter profile with 50% less light scatter. Also, that waxy vision that we all dread, where the patient has 20/20 vision, J1 plus, and they're seeing mid-range, but they still say, but doc, I just can't see well. And we used to hear that and other, multifocal lenses, but I'm hearing that far less with the PanOptix Pro. And I have to believe that it's because probably a clinical reflection of this 50% light scatter.
I haven't heard that term waxy vision since you just said that for a long time. Yeah. And I used to be very afraid of multifocals, honestly. When I was younger in my career, my first presbyopia correcting IOL was a accommodative IOL. And when I went and tried the early generation multifocals, I was burned.
Yeah.
I'd have those issues you described, and I have the unhappy patient. Mm-hmm. And just takes one of those patients for you to say, I'm never putting another one of these lenses in again. But it's amazing to look back at that and say, wow, the bulk of the premium IOLs I do now is trifocals. And now the PanOptix Pro is the primary lens I use. So what an evolution to go from someone, I'm a case example of someone who was totally afraid of multifocality to someone who's using it every day. That's a huge change over a period of time.
Absolutely. I agree. And that speaks to the undeniable patient and surgeon satisfaction. And there's been studies done to really review this. And more surgeons who have used the PanOptix Pro really feel confident recommending it to their patients as well as choosing it for themselves.
Yeah.
I often say that this is a lens I would choose if I were to have surgery today.
Yeah.
All right, so let's jump into cases and surgeon perspectives. I think these are really important examples. Hopefully our viewers will relate to some of these cases. We'll start with Rob. I'll hand this to you so you can control the
slides. So this first case is, a pretty typical case. I think a lot of us see it, very regularly. A middle-aged male, 59 years old, healthy, very active. He's hyperopic. He does not like wearing glasses. He wears them all the time. He is complaining of glare at night. It's one of his primary concerns. His cataracts are not terrible. He's not like one of these 3NS cataracts where it's like, oh my gosh, we got to get these out right away. They're a 1 to 2NS. He's even best corrected to 20/30. And he does have BAT testing down to 20/60, but he wants to do something. He has visually significant cataracts and complaints of glare. And in the past, this is, I think, the test case where the PanOptix Pro has made the big revolution for me in my practice. I might have been afraid of putting a multifocal in this patient in the past because they're complaining of glare. I don't want to put a lens in that's going to give them glare. They're used to high quality vision. They're super active and they don't have that bad of a cataract.
And they're a spine surgeon. So presumably type A, like some of us.
Yes. So this is the kind of thing where I've been pushing the boundaries, pushing my own comfort level as I've put more and more pros in. I'm putting them in professionals like this gentleman. So
a patient like this would come to you and say, I don't want any glare. How do you address that concern?
Well, that I would probably, if he was saying, the conversation with him, it usually doesn't really get to that. It usually says that I'll go through the benefits of this technology being free of glasses and being a really nice lifestyle for them, and giving them the caveat that the only downside that I hear about is a slight glare at night, which you might not even see. But occasionally I do hear about it. But the benefit and upside is that you are going to be free of glasses, and the likelihood of you doing well with this lens is extremely high. I also tell them now, worst case scenario, if you don't like it, we can take it out. But I'm very comfortable with lens exchanges.
Yeah.
Yes. Not everybody is, but I think people are becoming more comfortable
that's
with
exactly the difference is that like you said, if a patient said, I don't want any glare, and you see that they have cataracts, they say to you, I have glare right now, that's why I'm coming in. You see the cataract. We used to hesitate recommending the PanOptix,
Yes.
right? We used to or a trifocal for that matter, maybe lean towards Vivity more. But I think more and more, like you said, we have the confidence to recommend it because we're seeing patients who are having such fantastic results without really complaints around the
I
vision
still think
quality.
it's important to set realistic expectations. Like you said, you still counsel all your patients. You might still have some glare. We're not going to promise 100% glare free. But like Rob said, there's an exit plan. I'm happy to exchange it for you if it doesn't work out. But in my experience, most patients tolerate this no problem.
Yeah.
And I think also making sure that the patient and the surgeon are using the same terminology and know what we're talking about. And so I like to use educational tools to help with that. Different software programs that can show, here's what the nighttime vision might look like. And there's programs out there that will show a video driving down the road and all sorts of different conditions, stopping at a stoplight, showing the patient what they'll see carries so much weight, so much power. Then they say, I can tolerate that. My vision's already worse than that at night. That's okay. So sometimes making sure that we're using the same words in the same manner, that communication's important.
And the grade of the cataract plays such a huge role.
Absolutely.
For people that are just getting into this technology or want to dabble in it first, see how it works, pick a denser cataract.
Yes.
That, the patient already has tremendous glare at night. This is going to be less glare than
Someone
that.
with cortical cataracts with significant glare, where you can, with assurance and confidence, say that any visual aberrations you have with this lens will be less than what you have with your cataract.
Ultimately, it's nice to give the patients their own choice in some if you make the recommendation, but you say it's your choice. You could have no glasses and maybe a little glare at night or zero glare at night, but you're going to be tied to reading. Get them engaged, help them make the decision so they take some responsibility.
And I think that's a pearl too. Sometimes we hear the patient already has glare. Oh, I need to avoid a glare causing lens. But then they say, oh, but I'm used to it.
Yeah.
I'm okay with it. Anything better than that would be better.
Yeah, they might choose that over having to wear reading glasses.
Exactly.
That
So how did your patients do?
So we went over this a little bit. This is a comfort level that I've gotten to recommending these lenses in these types of highly active professional patients with less of a cataract. And we went through the thinking on that, and we discussed everything like we just mentioned. He did opt for the PanOptix Pro, and he was motivated. He really didn't want to wear glasses, and he did phenomenal with it.
Wonderful.
So I'm going to pass over to Mark.
Okay. Great case. Thank you so much. I'm going to talk about a case, a patient of mine. And this is a patient I was actually pretty jealous of. He's the same age as I am, but he is retired. He's a retired insurance executive. Very active person. He loves to play golf, fishing, coaching. So an active lifestyle. He really didn't want to be slowed down with glasses and contacts. He wanted to enjoy his very active young retirement. On exam, he'd had LASIK previously, myopic LASIK back in about 2001. He had about a 2 to 3 plus PSC cataract, normal macula. That's an important point. I always will look and check at the macula, make sure the macula is healthy, standard of care. But great looking macula, good exam, wanted distance, intermediate, and near clarity. Particularly, he loves to fish. He's a fly fisherman. He wanted to build those flies, tie the flies. And so when we talk about near targets, understanding, someone brought this up earlier, what is their near? Are they just reading a book? Is it a backlit tablet? Are they doing three-dimensional activities like tying a fishing fly? Because monovision can give you J1 plus reading, but it doesn't give you the depth perception. Where this gives you not just the near, but the depth perception at near, the depth perception at mid and far. So this is why I began talking about it. However, in the earlier era of multifocal, trifocal, we're often told if someone's post-LASIK, maybe the glare halo they already have from LASIK is going to worsen things. Maybe they're not a good candidate for this. So we test these patients with the eye trace in my clinic, a topographer, tomographer, OCT, and the Argos. Why? Because I want to let the data drive the decision with the patient and I. Just because they've had LASIK before does not disqualify them. They may have a very beautifully performed treatment. It's a central ablation. There aren't a lot of higher order aberrations. It wasn't a -8 ablation. They're going to do great. And so you can tease that out from the data from things like the eye trace and topographer. Originally, we considered the LAL. When the LAL came out, we went in heavily with that technology because we have such a high percent of our patients who previously had LASIK. And it was described as being very forgiving because you can modify the lens. And Rob had mentioned he's not worried about IOL exchanges anymore because he's good at it. Well, I got good at IOL exchanges in the last year because of the LAL, because these patients they'd hit their target, but they wouldn't see clearly, or they weren't getting enough near. Whereas in my post-LASIK patients that get the PanOptix Pro, who have the appropriate cornea, who have the appropriate macula, they do great, and they can see all 3 distances. And so we pushed him towards this, and the Pro is going to provide the full range of vision, quality of vision, the active lifestyle. It really fit him well. And my takeaway is don't shy away from trifocals in post-LASIK patients. You'll be surprised. And again, the panel here brought up a good point. When you're starting with new technology, start with a patient that you think you're going to hit the home run with.
Yeah.
Start with that patient who maybe had LASIK in the past, but it was a -2, okay? A lower treatment, maybe a cataract in place. Hit that home run, gain that confidence, and then start broadening your patient population.
I agree. I think it is a great option for these patients, but as you said, I think it's for someone who hasn't really dabbled in this, it's probably not the first few cases you should try, but most definitely an option to consider. Yeah.
Let the diagnostics and data help you with your decision.
Yeah, I think it's another great example of how the latest generation of this technology allows us to push the boundaries a little bit. You're hearing our colleagues saying they're putting it in post-LASIK eyes, like Mark's doing, which I just say a few years ago, nobody would think about putting a multifocal. But like you said, I think the cornea is incredibly important.
Yes.
And any high order aberrations on the cornea, that's a real red flag for the multifocal. But there are plenty of people who've had low treatment myopia treatments in the past for LASIK or PRK. Their corneas look kind of normal.
Yes.
Yeah.
And those are the ones that I'm comfortable doing the same thing in.
So post-hyperopic LASIK?
Yes. Hyperopic LASIK is going to induce some spherical aberration into the cornea, and it's
I think case
can
by
affect
case.
things a little bit. So it's a little bit case by
Yeah.
case. You have to look a little more carefully at angle kappa, angle alpha, I think. But I have done this. Yeah.
I've done it for both post-hyperopic and post-myopic LASIK too, and it really just shows you it's not black and white. You got to look at the cornea, do your due diligence. You got to talk to the patient. Some patients, these are patients who really want spectacle independence. That's why they got LASIK in the first place. A lot of them don't tolerate monovision, and so this can be a good option in the right patient.
Absolutely.
But I think this is again where the technology is not limiting us.
Yep.
But it may be the patient's anatomy, the ocular health, their expectations. And, I have this conversation with patients all the time about making sure that we are, the house in which this fantastic lens is being implanted into, it's optimized, and the house includes the expectations of the patient.
I love that analogy. I'm going to borrow that from you.
Yeah. Exactly, and it's like nesting. You have to make sure that, right, Dagny, nesting. You got to make sure everything is optimized, including the patient's expectations.
Yes.
And in offering this lens, the technology is not what holds us back.
Yes.
No, and the post-LASIK patient really has two challenges. One, you got to hit the target, which is a little harder.
Yes.
And then two, the aberrations and the side effect profiles have to be minimal, depending on how aggressive their corneal changes are from the refractive treatment. So it is a little higher stakes, but you talk to the patient about it, and the better communication you have, they know what they're getting into. They know it may not be perfect. They might need an enhancement. There might be more glare than somebody else at night. So as long as they're on the same page with you, it works out well.
They tend to be a little more savvy. They've been through this rodeo before. You know, they've been through eye surgery before. They know what the surgery's like. They know post-op recovery. They know vision terms like that we're discussing, and so I find it's a little easier to talk to them. They seem to understand it better.
I think in my experience, the most ideal patients, and love, Dagny, your comment about this too, the hyperope who has significant cataract, the ideal first patients.
Yes.
All right. Hyperope, significant cataract, may not even notice glare and halos from their cataract, slam dunk. I think that patient.
And minimal driving at night, most of their life is up here.
That, I think, if the patient comes in, says, I don't care one way or another, really it would be a shame for them not to have this lens because it'll be life enhancing for them in the sense that it'll give them freedom from spectacles as much as possible. Another patient would be a myope who's accustomed to reading without glasses but is really motivated to have distance vision too.
Yes.
But in that scenario, I spend time explaining to them that their near is not going to be magnified like their near is for the -4 patient, right? Because that -4 patient is very comfortable taking their glasses off and threading a needle.
Yes.
So I tell them, yes, I can give you great distance vision full range of vision, ability to also read or look at your phone without glasses, but probably you'll have to wear glasses for threading a needle, maybe.
Yeah.
Because that magnified vision, you're not going to have the same. Those are kind of the classic two, I think, who are great starters. But then, as was discussed here, we can expand that, right, to all types of patients, the high functioning executive who doesn't have that much cataract, the post-refractive. I think these patients can also benefit from this technology. Yep. Maybe we can move on to Dagny's case.
All right, so they asked us to choose cases that were not slam dunks. These are real world cases. And so, let me go back, don't want to give it away. So this is also, Rob had a healthcare worker, and I do as well. This is a female nurse, 59-year-old, kind of high maintenance, type A, drives a lot in the dark, early morning shifts, like 2-hour commute every day. But she also wants to be glasses free, does a ton of computer and paperwork as part of her job. So she wants a full range vision. Of course, everything is normal, luckily, when I do the exam from front to back. Little trace ERM in the right eye, but otherwise foveal contour looked good. And so I think the majority, or at least my patients, the majority, fall into this bucket where they kind of want it all. They want the full range of vision, but some of these patients drive a ton and they're worried about their night vision. And so as much as we've said, PanOptix Pro is great, especially compared to the other IOLs on the market, previous generation, really fewer complaints about halos and glare, it's still something that I'm concerned about. Some of my patients are concerned about, especially being in LA. So many of our patients drive through traffic at night, right? So for me, the way I was thinking about this when I initially heard her story and her lifestyle, I was like, oh, this is a bilateral Vivity patient for me, Same thing when I have those nighttime truck drivers driving 10 or 12 hours at night. I was like, bilateral Vivity, it's gonna give you the best nighttime vision, which I think is gonna be important for her. But she really, really wanted that spectacle independence. She was really pushing it with me. So in that case, I was like, well, what do I do? Do I take the risk? Do I do bilateral PanOptix Pro? Because it is so much better now, but I still had that feeling in the back of my mind, she might not be happy with her morning commutes. And so I did something kind of unique. I don't know what you guys would have done in my situation, but you probably have to talk to the patient a bit more. But I've been doing this more and more, and that is the custom match Vivity PanOptix. Yeah. And now with the Pro, that's how I'm using PanOptix Pro. And it's funny how we're talking more and more about this concept. I was at ESCRS recently, and there are a ton of surgeons around the world who are adopting the same approach, and we've all come to this approach independently. Mm-hmm. We've just found that there is a large portion of patients who wouldn't necessarily be satisfied with bilateral Vivity. They don't like the idea of having to put readers more often. And those who do quite a bit of nighttime driving and may not be comfortable with the idea of bilateral trifocal full range vision lenses. And then they get stuck in this analysis paralysis. They can't decide, do I want Vivity, do I want PanOptix? Then they end up canceling the surgery altogether. And so I've had this discussion with David Chang. He calls it surf and turf. With the Vivity and PanOptix mix and match, we can offer steak and lobster, the best of both worlds, right? You don't have to compromise. And when you set this discussion from the get-go and explain to them this is what we're targeting rather than as like a contingency of like, oh, we'll have to do the second eye a different lens because you weren't tolerating the first one, patients really jump on board because then they're like, oh, I don't need to make this decision. I get to have the best of both worlds. And that's what I did with this patient. And I've done this approach now in more than, maybe even 1,000 patients. And I've recently published a manuscript that came out a month ago showing the Clareon Vivity PanOptix outcomes. And these patients are so happy. They retain very high levels of spectacle independence, J1 or even J1 plus, but much fewer complaints about dysphotopsias for this type of patient group that I'm worried about. And so that's what I did with her. She was really open to the idea. She liked that idea that she wouldn't have to worry about the nighttime driving based on my experience. And so that's what I did for her, and she was very happy. She ended up 20/20 J1 plus binocularly. And it's not monovision. You get great binocular summation, distance, intermediate, and even at near, just the PanOptix gives a little more near than the Vivity, which gives functional near.
So which eye do you like to do first?
People love to ask that question. So a lot of us that are doing this, we're actually doing bilateral same day. And so we're really committed to this is what you're getting. And I think it helps with the neuroadaptation.
Do you pick the dominant versus non-dominant? Or
now, if you're doing it one eye at a time, which most surgeons are still most comfortable with, typically we start with the worst eye, right? the eye that has the greater cataract. So usually that's the non-dominant eye, so I would recommend starting with the PanOptix in that eye.
Or in this case, she had a slight ERM in one eye.
Thank you for pointing that out. So
Vivity.
it matched perfectly. I put the Vivity in the slight ERM eye, and we know that those patients do really well.
Great.
I think this is a great case, and I love your approach here. And I think this is a really good approach to take for patients like this who have really long commutes in the dark. I used to use this approach more with the PanOptix. Okay, the PanOptix led me to that. But I'm seeing less complaints about nighttime vision, so I'm tending to see this less with the PanOptix Pro. It's still good to have in your armamentarium, but I use this a little less than I did with just the original PanOptix. In part.
And I'm sort of the opposite. I was mix and matching a lot with the original PanOptix, and when the Pro came out, I was starting to use the Pro more bilaterally again.
Yeah.
And because I felt like they were getting better results. But there's still a handful of patients, and I think it's always, important to know there's still no perfect lens. We've still got to counsel them on, the halos and glare as being a possibility. And depending on what the patient is comfortable with, what you're comfortable with, this is a great approach, which you could offer patients that previously weren't getting either because they couldn't decide.
So the one thing with this approach is patients in the clinic will be able to read your card, but if they're avid readers, if they really like to sit down and get into a book for 3-4 hours, that's one question you might want to ask, because they're just not as happy for long reading, let's say 2-3 hours at a time.
Absolutely.
This is one reason, even in the era of bilateral same-day surgery, where this is a trend and moving forward in that direction, I still think there's a role, at least for me and for the patient, of doing one eye at a time, seeing how the first eye's doing. If they love the first eye, and maybe it's a Vivity, they may want the same lens because they love it so much, and no problem. Or if you put the PanOptix in first, if they don't love it, you could pivot, or if they're having concerns. But if they love it, you do the same thing. So I don't think there's any one right way to do it, which is a beautiful thing in our field, that there are so many different ways to craft things. But it speaks to the different options we have, and sometimes it's hard to choose what to do because there are so many options.
And I think all your cases are fantastic cases, and highlights again how we have now expanded our scope of offering advanced technology presbyopia correcting lenses, diffractive presbyopia correcting lenses to patients, and that patients do well, even if they don't fall into that perfect category of what the ideal patient would be. And again, speaks to the technology and how the tools we have in our hands now really can deliver on that promise that we have for our patients. And there's no reason why we should be stuck at the 20% of penetration, right? We really need to push that up. And hopefully, I think we're going to end this conversation, but I really want to direct this to you all, our viewers. Thank you for being with us. I really hope that for those of you who have never had experience with presbyopia correcting lenses, hopefully this discussion has given you some incentive and some excitement about trialing it and really implementing it in your practice. It has been a real practice enhancing opportunity for me, for all of us. It has given us and our patients really fantastic results. And I've really enjoyed really fine-tuning my practice around this technology. And for those of you who had tried presbyopia lenses before, diffractive lenses, and were burnt because of the results that you may have had with previous generations or other technology, hopefully this discussion has proved to you that there is change in this lens. PanOptix Pro really delivers, it's not a traditional trifocal lens. It delivers on really the advances in its technology by improving the mid-range vision. The distance is much more functional, and the quality of vision, due to the less light scatter, 50% light scatter, this is not your traditional trifocal. So I really hope that you come back to the world of presbyopia correcting lenses. And for those of you who've had great experience with PanOptix, PanOptix Pro is definitely an inch better. And as you know, in our experiences, we have noticed that our patients are describing even better outcomes. And obviously the data will speak for itself when we have that data, but our clinical experience has been quite telling and exciting. And with that, I'm going to give you a break, and hopefully you'll come back again for our next panel, who's going to be talking about Vivity, and we'll continue this discussion. Thank you so much for your attention, and thank you, dear friends, for your fantastic comments and really fabulous cases.
Thanks, Dad.
Thank you so much.
It's been great. Thank you.
Thank you. Hi, everyone, and welcome back. I hope that you had a nice break. Really enjoyed our conversation about the PanOptix Pro. We're going to move on now to the Vivity, and I have a wonderful new panel of experts and dear friends, all who have been along the road with me throughout the last several years, many years, actually. Let's not date ourselves. All of you have been real dear friends, a huge inspiration for me. I'd love for you to introduce yourself. I've already introduced myself to our viewers, but I'm sure they're dying to meet you. So tell us a little bit about yourself and your practice.
So I'm Neel Desai. I'm a cornea cataract refractive surgeon here in Tampa, Florida. And it's great to be with all of you and be amongst friends.
Hi, everyone. Preeya Gupta, cornea cataract and refractive surgery in Raleigh, North Carolina. And thanks for having me.
Hey, guys, I'm Clayton Blehm. I'm in Gainesville, Georgia, right at the foothills of the Appalachian Mountains. And it's a pleasure to be with you guys. We can learn all things Vivity.
Awesome. We're going to have a great half hour or so together. Let's jump right in. And again, this is our expert panel. Well, let's talk about Clareon Vivity. Now, we've all had access to the Vivity for a while now. This is nothing new, but definitely, I think, a new discussion around how it fits in our practice, especially now that we have PanOptix Pro in our hands and we're having such a great time with that. But how do you then fit Vivity into our practice? Who are the patients that we present this option to, and where does that discussion sit? So I'd love to hear, Neel, what do you feel about Vivity and how does it fit in your practice now?
You're so right. I mean, Vivity is not new, and nor is the philosophy that we approach patients with. I think our general philosophy is to treat every patient like a refractive cataract patient, because everyone wants to see the best they possibly can. And for a long time, we didn't have great options for a subset of patients. PanOptix, blowing it out of the park, it's my fastball. But for those patients that may not do so well with a diffractive optic, patients with ocular surface disease, compromised contrast, they're just not ideal candidates for a diffractive lens. This becomes the best option for them, for those motivated patients that really want seamless range of vision, more natural range of vision, functional range of vision without the downsides. And I think that's really important when we talk about any ATIOL. The cost of entry to this arena for patient satisfaction is really that quality of distance vision. And then the range of vision is almost secondary to that. And so having an option that's non-light splitting, that can really achieve great quality distance vision and give these patients functional range of vision has been really nice, and it's been additive to the practice.
Yeah, absolutely. I think another message I have for some of our colleagues who haven't dabbled with presbyopia correcting lenses is also that Vivity may be an option to really be an entry point into that. I think that also is a really good place for it to fit for those surgeons who are maybe apprehensive. Preeya, I know you've teach around the country, and what is your message about that?
I think that it's so important. Something you said, Neel, really resonated, which is I like to treat every patient as a refractive patient. They might choose distance, they might choose distance and intermediate, they might choose everything. And, our jobs as clinicians are really to figure out what will our patient accept and what would they not accept. And so, when I talk about Vivity, it's generally to a patient that has told me that they would not accept some of the kind of limitations of diffractive technology, right? So these are patients that want that crisp vision, but they want more than just distance vision. And so I like to talk to patients about, kind of getting 2 out of 3. So distance and intermediate. There's some strategies where you can help to increase the near, such as mini mono, which we can talk about. But it really is about kind of allowing them to participate in presbyopia correction in the ways that they want to. So a lot of my patients, are excited about the technology, excited to be able to have access to something more than just distance vision. So I think, for the docs out there, it is important for you to adopt that mindset of every patient might want refractive cataract surgery.
I think another important point is that a lot of patients don't realize that mid-range vision, you were talking about 2 out of 3, we see at distance, mid-range, and near. And a lot of times patients say, well, I don't work on the computer. I don't really care about having to have mid-range vision. But the reality is mid-range is not just the computer. Yeah. It's the dashboard. It's the kitchen counter. It's walking up and down stairs for elderly patients. So when you position it that way, and it's really important for patients to have that depth depth of focus, and Vivity does give them the 2 out of the 3, it really then adds an added value to our patients. And I think it's a really wonderful lens.
Totally.
Let's dive into, you touched on this, a patient who may have other comorbidities, someone who you may not want to recommend a multifocal lens to because they have dry eyes, or in a patient who has had LASIK in the past, for example. Clayton and Preeya, if you can comment on this, how does Vivity fit in that category of patients who've myopic LASIK in the past?
So isn't that great that up until a few years ago, if they didn't qualify for an advanced technology IOL, like we just didn't have a whole lot to offer aside from, a monofocal or toric. So I think we finally have this great lens that even with mild pathology, I've had a lot of success. People with mild Fuchs, maybe a few drusen, even kind of mild EBMD, where this lens is extremely forgiving, still allowing a really strong range of vision. And I'd love to tell them, the night profile on this lens in particular is really phenomenal. Very happy people.
So post-LASIK patients?
Yeah, I was just going to say, this is like my go-to for my post-LASIK patients. They're all bought into vision correction, right? They all spent money 20 years ago to get rid of their distance glasses, and they want something, again, to restore them from that sort of independence as much as possible. I don't like putting diffractive technology in patients that have had LASIK surgery because, of course, aberrations and, you just can't predict who's not going to accept diffractive technology. We know that they have aberrations as part of myopic and even hyperopic ablations. And so this is a patient population where I think the Vivity really does shine. It is forgiving, as you mentioned, but it gives them that broader range of vision, which they want.
I think also the landing zone doesn't have to be as precise with the Vivity. And so in a post-refractive, post-LASIK patient, if you miss that refractive target with a multifocal, it's more aberrations that they'd have to tolerate versus the Vivity allows a little bit more of a wider landing zone. Neel, you were going to comment?
I was going to say, when it comes to post-refractive patients, it's definitely a unique challenge because these patients were so used to exceptionally good quality distance vision. And they usually had their corneal refractive procedure when they were younger. They had some accommodation built in. And so they were used to that seamless range of vision. And so offering these patients, while I do offer PanOptix to them, it's not quite similar to what they used to have early on in life post-refractive surgery in terms of that seamless range. It's not steps and sweet spots. So Vivity kind of fits that patient profile. And I think it's really important to ask these patients and ascertain from them, were you happy with your initial corneal refractive procedure? Mm-hmm. Because if they were, then you've got PanOptix and Vivity to kind of choose from. But I think Vivity gives them a little bit more of that natural range rather than sweet spots and steps.
And the reason that question is important, if we can highlight for our audience, is because it means that the corneal contour is acceptable, sure, and hopefully it's not adding to the aberrations.
Yeah, if they weren't happy, ecstatically happy after their initial corneal refractive procedure, I usually see that as a sign of a decentered ablation or significant ocular surface disease or high order aberrations, coma, etc. And that patient may not do well with, frankly, any ATIOL, and it's a very different conversation. But for those that were initially happy, I think Vivity is a very suitable option.
So 95% of post-LASIK patients who had the Vivity would recommend it to their family and friends. That's quite telling. And 92% of post-refractive Vivity patients reported they can enjoy normal daily activities without the need for spectacles. That's really, really impressive. So I think it's a really great added benefit, and it's expanded our kind of armamentarium for our post-refractive patients, whereas before we used to hesitate recommending advanced technology lenses to them. So I'd love for Clayton, I know you're dying to explain X-wave technology.
So somehow I'm the honorary physicist of our group today, so I'm going to do my best on this.
Better you than us.
So X-wave technology, instead of having a diffractive method where light is split into several different focal points, this still maintains the single focal point at distance, but stretches that depth of focus. So there is no splitting of light. We consider this more of a stretching effect. And so there's our X-wave technology. I think it's really important to note, on the slide that the monofocal IOL still will have some degree of glare. Maybe a glow perhaps is what I'm seeing there. Nothing may make perfection. Let me rephrase that. We may not get that perfect image at night, so you can still see those quite similar. So we're not seeing the halo effect typically with Vivity. It's a much more similar night profile toward the monofocal IOL.
Yeah.
And again, that's one thing I love sharing with patients, particularly if they're either truck drivers or, I joke a lot with my older patients if they're out partying all night long. This is still a great go-to lens for that type of group.
I have to say that I'm sure you agree with the PanOptix Pro. I'm emphasizing nighttime glare and halos less and less, and our discussion earlier on will highlight that. But there are patients who still hesitate, who still, even with my enthusiasm around the PanOptix Pro, they still say, well, I'm not sure I want that, or I'm a night driver, I'm a pilot and such. And so I used to jump right to Vivity, but now I do emphasize, again, the nighttime glare and halos with PanOptix is not that significant, but now it's the patient's hesitation that leads to me having then recommend Vivity to them. So I agree with you. I think Vivity definitely has probably less nighttime visual aberrations than PanOptix Pro. But at the very least, it's easier for us to address a patient's hesitation when they are worried about a diffractive lens. Would you agree?
Yeah, I think it's really important to listen to what patients are saying.
Yeah.
I usually, I always start with describing trifocal technology. And then after I've my one or two sentences, I will always say to the patient, if you're type A, super picky about your vision, or if you happen to be an engineer, you might not like diffractive optics. It just, we don't have a way to predict it. And then, can seamlessly describe this stretching of the wavelength of Vivity. And I think it's, well, yes, the technology for trifocality has really grown leaps and bounds. There's still a segment of this population that, would consider any halo or any glare to be like a failure of their surgery. And so I think it's really important to tease that out. And, Vivity, in my hands at least, has most definitely not been something where patients are describing kind of a heavy burden of nighttime visual disturbance.
Does the degree of cataract guide your recommendation? Meaning if someone has milder cataract is what we call a Beverly Hills cataract, in LA, versus someone who has very, very dense cataract, cortical cataract, who is forced to come in by their daughter because they barely can drive anymore. Does that guide your discussion?
Absolutely. So the more the patient's complaining of glare on intake,
the
more free I am to offer them a PanOptix Pro, because I know in the back of my mind, the dysphotopsia profile, even with PanOptix Pro now, is very friendly, very minimal, but it's a slam dunk. But for the patient, oftentimes it doesn't come down to hard metrics or biometric factors. It comes down to a personality read of our patients, that we're making a snap decision within a few seconds and saying, well, this patient's a little bit more demanding. They may not enjoy even a small amount of nighttime dysphotopsias. And then I'm much more inclined to kind of set expectations a little bit lower so I can over-deliver with a Vivity and really knock it out of the park.
They have a 20/30 cataract, 20/25 cataract, and bitterly complaining about nighttime glare and halos, the Vivity would be a much better option for them.
I agree.
Right? So let's talk about matching kind of the mini monovision to really help patients with freedom from glasses. I know with Vivity, there's a lot of different approaches. Love to hear, Clayton, if you can kind of explain, when you see a patient, you're now decided Vivity is the best option for them. Are you doing plano for both eyes? Are you doing a little mini mono? How are you approaching the refractive target?
Great question. We developed an extremely simple questionnaire of just how many hours a day do you spend at intermediate type hobbies, how many at near. And so it gauges, for me, how important is that near vision? If it's such a low amount of time, then I could easily lean in toward Vivity. And those patients, I might target plano in both eyes, particularly if they have any kind of other compromise in the eye. I feel like I may not want to do as much offset. But I will say the average healthy patient that doesn't mind wearing reading glasses occasionally, or maybe doesn't have all that much activity right up close, it's still quite easy to do an offset of plano minus 50 is kind of my go-to to give them a really strong range of vision without having that huge offset of anisotropia.
So do you check for dominance then when you assess the patient?
I do.
Okay. And your go-to is minus 50 for the non-dominant eye?
Correct, typically. Yeah, and I will say, a lot of taller gentlemen, I'm 6'3", I tend to hold things a little bit further away. So I'll have that discussion with taller folks as well, just to see if I even need to do any offset.
Awesome. Preeya?
Yeah, I primarily do some sort of mini monovision with Vivity. I definitely check dominance. I always do their dominant eye first if given a choice, because then you can kind of see, refractively, like where did they end up? You can kind of get a sense of if they're happy with their intermediate and functional near. And then in the non-dominant eye, so if they've done monovision in the past, I don't even ask them.
Yeah.
I mean, it is a -75 target because I don't know anybody that does monovision with less than a diopter, right? It's often 2 diopters plus. And they're some of my happiest patients because they get their binocularity back, right? 0.75 is just not, it's very tolerable to most patients. If they've never done monovision, we actually do show it to them in clinic. Mostly because I think it's just my practice. I have that type A patient that always like naturally comes in and finds me. But, if they've never done monovision, a half diopter, while it's not that much, like for some patients, it's a big deal. We just take, the goofy little trial frame, put their refraction in it and just put up +0.5 or +75 in front of it to show them what they might lose at distance. And the vast majority of patients at that -0.5 hardly even,
And this is for your cataract patients.
Yes, for the cataract. Yeah, so I mean, they can be in that Beverly Hills bucket,
Yes.
It is very hard to show somebody if they're, 20/80. You kind of take a leap of faith. But
highlighting the fact that half the diopter is not really that much. It's even with cataracts.
And if you look at the defocus curve for Vivity, at -0.35 and less, there was no loss of 20/20 distance vision. So it's when you go much over that 0.35 where they start to lose a little bit at distance. Most patients will tolerate that and want to get a little more near. But, I also have patients where I know, like you were describing, like, hey, this patient will not tolerate anything other than plano in each eye. And, they're super happy because they do get that range.
Neel?
Yeah, my approach is maybe a little bit more customized. I don't have a hard and fast rule per se, but I do think it's important to identify dominance. I try to do the dominant eye first as well. And you mentioned the landing zone being a little bit more broad than we're typically used to with other EDOF lenses or multifocal lenses. And I use that to my advantage. So I'll actually target the dominant eye dead closest to plano, even if it is the first step hyperopic. Those patients have fantastic quality distance vision. And then the non-dominant eye, I can kind of play around with it a week later. We're seeing what their first eye is doing. We're talking to them in moments before the surgery that morning. And we ascertain whether or not they're really happy with their intermediate range. And I might go up to about a -0.3, -0.5 at the most. But I think in my experience, when I start pushing it beyond 0.5 of defocus, I think there's a little bit of a detriment to the quality of distance vision. And as I said earlier, I think the cost of entry is that distance quality. And so even though you might gain a little bit of that near, when patients are dead plano in both eyes with Vivity, they've got really a good functional range of vision. And I don't want to take anything away from distance.
It really comes down to the patient's motivation and how much they want to have freedom from spectacles, right? But if a patient says, I want the best distance vision, I'm okay wearing reading glasses, then in those cases, plano. But those patients who had the Vivity and had mini monovision, 97% of them indicated that their visual goal was fully or partially achieved. And that's definitely been in our practices too, that we've had that experience. This is a great study, Clayton, that you looked at the light adjustable lens. And I know that we all have dabbled in different types of lenses when a patient is a great candidate for monovision. And light adjustable lens has been a great option for in my practice, and I know in yours too, as a way to get patients to that monovision outcome. But it is quite labor intensive. And I know that you were trying to decide if in your practice it fits, and how does it fit with the monofocal doing monovision? Tell us about the study.
Yeah, I'd love to. So first of all, when you're thinking about any non-diffractive technology, I think it's really important to understand all the tools we have in that box right now. So of course, the light adjustable lens has come along. It's been a fantastic technology, and it still serves, a really important place in my practice. But I had the curiosity early on of just how much depth of focus were we getting when we were using the LAL. So we designed a study to compare just standard Clareon monofocal/monofocal toric and compared that to a light adjustable lens. And just to make the study easy and apples to apples, all the dominant eyes were targeted at plano, all the non-dominant were targeted or treated to -1 if that were the LAL group. And surprisingly, you look at the defocus curve and you could almost trace those lines together. I was really amazed at that. So there really was not much depth of focus even after each treatment of using the LDD device. The only significant point on that whole defocus curve was at the -250 point, so right up close. The LAL group did achieve 3.5 letters, so not even quite one line of vision. But of course, we all know if you've spent any time performing LALs, it's a lot of patient visits, it's a lot of clinic time. And I tried to flip that switch in my head as what is that from the patient's perspective or from their family member that's driving them back and forth? It's a lot of time in clinic for them to get refracted, dilated, wait for the surgeon or OD to perform the laser device.
Well, in fact, 3 times, three times more postoperative visits compared to the PCIOLs, presbyopic correcting IOLs.
Correct. Without much vision benefits. And at the end of the day, you're still performing some type of monovision.
And going back to this fantastic study, we're awaiting your next study where you would hopefully compare the same, with Vivity versus the light adjustable lens. And I think we can extrapolate from this study that if with a monofocal you were able to gain or achieve the same kind of outcomes as the light adjustable lens, I would imagine with the Vivity with mini monovision, at the very least, it'll also be the same, if not maybe superior in some ways. So, but that is yet to be determined with your next study. Good luck to you.
Thank you.
But again, Neel, we all know, yes, light adjustable lens is most definitely a wonderful lens and in our practices. But as far as a patient we know has maybe a virgin eye, has never had surgery, wants monovision or wants freedom from glasses, they've never tried mini monovision before, Vivity is a wonderful way to get them there without the labor-intensive approach.
Yeah, I agree. And I kind of use a baseball analogy here. As I mentioned, PanOptix Pro would be my fastball. It's a very consistent pitch. Mm-hmm. I can throw it, but you're not going to win a game as a pitcher throwing a fastball in every single situation. Vivity is sort of that change-up pitch for those specific circumstances where you need something a little bit different, but it has to be still consistent and reliable. LAL is sort of that curveball. It's a very niche kind of placement in our practice. We do offer it, typically in very high type A, high maintenance personality type patients that are post-refractive, post-RK. But that's not certainly the vast majority of our patients. And ultimately, when we look at our overall outcomes, our enhancement rates are less than 1%. We're getting good outcomes with almost every single lens we might use. To me, LAL seems like it has a 300% enhancement rate because it requires those adjustments. And ultimately, we're getting to the same place as you would get with regular old monofocal lenses with a little bit of mini mono or monovision targeting. So I think it's a great technology, but it has a niche placement in our practice. And I would agree with that prediction that Vivity with a little bit of blended vision is going to be a lot more natural than a true monovision that you'd get with a lot more effort with an LAL.
Wonderful. So I think to summarize before we get into your cases, Vivity offers truly clinically proven low visual disturbance profile with a nice depth of focus that covers 2 out of the 3 kind of focal points that we live in. The X-Wave technology that Clayton so beautifully and expertly explained really shifts light without splitting it for nearly 100% utilization with negligible light scatter. So nighttime visual aberrations are minimized as a result. And it's proven to be really effective in a diverse group of patients, including post-refractive, post-LASIK patients who have low aberrations of their cornea, as well as those who want to do monovision. So I think it's a really great tool in our armamentarium, and it has rounded out our options for our patients who are seeking spectacle independence. So with that, we're going to jump into your specific cases. Clayton, maybe I'll hand this to you, maybe pass this on to you so you can go through your case.
Thank you. At the top green, I'm assuming. So I had wonderful lady that came in. She was very young, 50-something young woman that was still a career person, probably another 10 to 15 years ago, and had previously had LASIK, monovision LASIK, and had been living with that for about 15 years. But just her terms, she felt off balance and decided to go in for a cataract consultation at a local practice. And, they raved about the benefits of using the light adjustable lens and how much more accurate that they should be able to mimic her monovision. But something still just didn't sit right. She just did not want that feeling of being off balance. So she presented at my clinic at that time, and we of course discussed that option of continuing with the LAL and maybe even trying a smaller amount of monovision, and just thought she really didn't care for that option. So we brought up the option of Vivity implant lens to still give her wonderful range throughout, and her activities were mainly for her near business was more on the desktop computer. So she was out closer to 18 to 20 inches and was thrilled with the idea that she could regain binocular vision, but still maintain, her distance necessity and, of course, some of her career work at that intermediate range, and was okay if she had to use some readers every once in a while. So we did make the choice to move forward with Vivity implants in both eyes. We chose a plano in the dominant eye, -50 in the other eye. And that was, of course, our initial direction. Final decision, as we mentioned. The takeaway from this, she was so thrilled. She was back binocular 20/20 vision, J1 plus at intermediate, and ended up in that J2, J3 range at near, was absolutely ecstatic. That feeling of just being off or a little bit dizzy was completely gone and could not have been happier. And I think for this patient, in a post-LASIK situation, I also lean more toward non-diffractive lenses in that group of patients. And I felt like we both hit a home run. We were both so happy and smiling on that final post-op visit.
I think this is a great case that highlights also that patients who had done monovision when they were younger, and they may have outgrown their monovision as a result of ensuing cataracts or changes in their optical system, we can't assume that they'll be able to tolerate monovision to the same degree as they had before. And so it is challenging in these patients because they often feel imbalanced, or we need to understand that maybe when she had monovision with her LASIK, it was an offset of -1, but her needs are much greater than -1 offset now. So the Vivity, I think, allows for us to be able to give that milder offset and yet give them as much independence as possible. So this is a fantastic case highlighting, again, mini monovision for a patient who's not tolerating full monovision, as well as someone who's post-LASIK. So thanks for the case.
Yeah, thank you.
Yeah.
Yeah, I would say just one of I get asked all the time, what do you think I should do?
Yeah.
Right? She did monovision for all these years. She doesn't love it. But you said something very important, which is she's okay with readers sometimes, right? She doesn't want to wear readers, right? So that is you have to kind of piece through, if you had just done a distance target in both eyes, right? Even though she was going to get the intermediate, she wouldn't have been happy, right? If you had targeted, a -1 with the Vivity, she probably wouldn't have been as happy as the target that you chose. So I think kind of listening, patients pepper in their expectations, thinking that it's not that they don't mean different things. And so I think, for everyone out there, it's really try to hear what your patient is actually where are they functioning? Where's their 80% of their day? What's a deal breaker? What do they not like? Because I think that'll help you, with the special sauce of Vivity, right? Where do I target? Where do I, who's the best candidate for a distance target versus a mini monovision target?
But doesn't that make sense? We're kind of playing the role of matchmakers.
Yeah.
We've got this wonderful patient, and it's really our duty to them to explain the options, but make that recommendation.
Totally.
I think they really need that.
But I think, Preeya, you highlight again the importance of listening to their story, but also understanding how do they use their eyes and what are they accustomed to. So I often ask, walk me through your day. When do you put on glasses? When do you take them off? So that they understand and you can understand, are they someone who is accustomed to not needing glasses for reading or working on the computer? Because I've been burned, they come in, they say, I want excellent distance vision and great, and I'm okay wearing reading glasses. or they may not even say that, but they focus on wanting excellent distance and mid-range vision. So you then implant Vivity, but then they come back and say, but I didn't have any problems with reading before. Now I need reading glasses. So it's important for us to understand what they're accustomed to highlight to them there's a trade-off to everything, right? Vivity is amazing to cover 2 out of the 3 distances. But if a patient's accustomed to not needing reading glasses, then you need to offset and give them that mini monovision, or at least have a conversation about targeting, if they want mid-range and near and okay wearing driving glasses, then you target differently, right? So I think that conversation is really important, and asking patients, how do they use their eyes? How do they use their spectacles or contact lenses to understand what their baseline is?
Isn't it great, though, to listen to all of us talk about these lenses? We're talking about the lenses and the patient-focused outcome, but it's freed us. The technology has freed us to not have the conversation about the technology with the patient. So the conversation has become shorter and simpler, where we're focusing on the outcome, not the technology itself. And it's really neat to see that transition.
I love that. Next case. Let's see, Neel.
Yeah, so great case, Clayton. I'm going to share a case of the 73-year-old who came in with a previous diagnosis of open-angle glaucoma. Obviously, that's going to bring up some concerns as to what kind of IOL we might use to replace her cataract with. She's been stable on latanoprost for years, family history of glaucoma. She's an avid reader. She does most of her reading. She's pretty savvy. Most of her reading on an iPad. So I'm now thinking, okay, she's got pretty good contrast with that backlit iPad, but she has also some compromise to her contrast with the glaucoma history. And her ocular surface did look a little bit rough because of years of latanoprost. Her vision was 20/50, 20/60. She had moderate cataracts, mild ocular surface disease, and irregular topography. So I kind of launched into our ocular surface optimization protocol. And for her, I thought there was an opportunity here to offer her, as part of her ocular surface optimization, the opportunity to get off of the drops. And so we actually did a Voyager DSLT bilaterally for her, and then repeated biometry about a month and a half later. And her ocular surface looked better. Her pressures were stable. And I now was saying, okay, well, I'm not going to necessarily need to put in a stent or do canaloplasty. I can just focus on the cataract. And now what options do we have? Years ago, this would have been a patient, I say at most we were doing a monofocal or a monofocal toric, and I'm bunting, to use the baseball analogy again. But now that I've got her ocular surface optimized, I realize I've got a lens that doesn't really compromise contrast sensitivity for her in the same way that a light splitting lens would, or a typical conventional diffractive lens. I put Vivity back on the table for her, and I chose just a quarter diopter offset for her, because I really think she wanted the distance vision. And she expressed to me that she was totally fine wearing reading glasses. She was used to it.
Mm-hmm.
And I thought, well, I can set the expectations here and really over deliver. And that's exactly what happened. I was very pleased to report. So that X-Wave technology really did come to play, but we didn't have the conversation about X-Wave technology. She ended up, So she ended up 2020, J1 plus bilateral summation, and her glaucoma is still stable to this day. So I feel really good about that, and really good about having that opportunity to offer her and speak to the best of her goals and the highest level of her goals, and treat her like a refractive cataract patient, even though she had some other confounding factors.
I think your case highlights the importance of still not ignoring what's necessary to get the best outcome for these patients, whether they have a monofocal or toric or Vivity.
Sure.
And I agree with you. I think the focus is no longer on the limitations of the technology like we had before, where we would hold back options from patients because we felt that the technology wasn't going to deliver on the promise that we had for that patient. It's now, what are the limitations of the ocular health, the patient's expectations? Can we meet them, right? The technology is there, but do we need to lower the expectation of the patient or improve the quality? So here's the quality of the health of the eye, improve it to match the technology. And the Vivity is a really wonderful option for patients like you just described, but it's still important to have the conversation with these patients, is that, especially because they're likely going to be paying more for this technology, that it's still limited, not because of the technology, but because of the ocular health, because you have glaucoma, because you have dry eyes and it needs to be maintained. So if the outcomes are not where your expectations are, it's not because the technology didn't deliver. It's because maybe your expectations were not realistic and such. And so we have I do this a lot in clinic. The health, we got to bring it up. Your expectation, we need to, but the technology is really the best it has ever been. And I think the Vivity is a lens that's given us an option to really expand the opportunities for our patients more and more.
Absolutely.
So.
Neel, could I commend you? So two things that you mentioned that I love is one, it does take patience to treat the ocular surface because you're ready to get in. You've got some measurements that might be okay, but I love how you took the time to do a DSLT, get her off the medicine, optimize her ocular surface. The other point you made that I also love is the fact that she was a digital reader. She had an iPad, a tablet, and I've started to think differently on what kind of near vision are you utilizing? Is it more of a book and paper source, or is it a digital background that's backlit that can have a font adjustable size? And I'll talk to my patients about that, hey, you're probably going to have a higher chance of getting out of glasses at near if you don't mind just blowing that screen up a tiny bit or using a backlit product. So I'm glad you mentioned that.
Also important to ask patients, where do you think mid-range is? Because I've had patients say, yeah, mid-range is here, right? And so really important to point out what mid-range is for patients. Well, thank you for this fantastic discussion. I hope that our audience got some pearls out of these incredible expert panel and the cases that were presented. I think Vivity, again, as mentioned, is a wonderful addition to our surgical armamentarium. It has been in our hands for a while, and it continues to be a real wonderful opportunity for us to expand the opportunity for our patients to have freedom from spectacles as much as possible, especially for those nuanced cases or patients who are apprehensive about the diffractive technology in multifocal lenses. Thank you again for your attention.